Good evening, ladies and gentlemen. This is your friendly neighborhood ophthalmologist Sashwat from Medway, taking you through the recall session of FMG today. Now, I know that it is difficult for you to remember the questions after traumatic exams, where many of you are not able to recall your own names after exam. But we thought that we would bring you a quick, while the cakes are still hot, so to say. So to give you something quick, which at least you should know the answers. The explanation we can come out with later. Okay, I will come back in a couple of days when I gather all the questions and explain everything. But at least today you should know the answer. So you should get how many of you have scored well. And this time the impression that I have, that often talking to some of you, is that it's not in ophthalmology. Remember, I'm talking about ophthalmology. Is that it's not a very difficult paper. It's a straightforward. It's not easy, but it's straight. It can be done. Okay. So since it's a live session, we'll be talking to you, and if you have any queries, if you want to add some questions, some choices which you do not have. See, the trick about an MCQ is not about the question, it's about the choices provided, okay? And the choices, when the question is simple, the answer can still not be simple just by manipulating with the choices, okay? So you have to be very careful about the answer. So the impression I've had this time is that the choices were very difficult of all the subjects. It's not a simple answer, okay? So kindly correct them. Since it's a very short session, I will take not more than 10-15 minutes of your time. Those of you who are watching, I hope some of you do watch, and please interact with it. It's a live session. So if we have any questions, so here right now, look at the first question I've had. The normal flora in conjunctiva, a very, very important question. The most common normal. See, there are a lot of normal flora in the eye. You can have Corynebacterium xerosus, you can have streptococci, you can have staphylococcus, but the most common, and I have told them many times, normal commensal or ocular flora in the conjunctival sac is staph epidermidis. Please remember, it is staph epidermidis is the most common. You can also have staph aureus, but this is not so common. So number one, the most common, if the MCQ is the most common ocular flora, it's going to be staph epidermidis. Okay, very well. So that was the first question. There's no doubt about that. It's a memory question. You have to remember it. Like sudden painful loss of vision, and the picture was possibly of a mid-dilated pupil. So you can have many causes of sudden painful loss of vision. Like what? Well, with painful loss of vision, it could be optic neuritis also. You can have optic neuritis with retrobulbar neuritis. Okay, you can have some trauma. You can have chemical injuries. You can have corneal ulcer. But when you have a sudden painful loss of vision with a mid-dilated pupil, as I understand the question was either as a photograph or an image or this, then the answer is only acute angle closure glaucoma. Sudden painful loss of vision with a mid-dilated pupil. Mid-dilated pupil, of course, is the giveaway clue. Okay. Optic neuritis, yes, is also painful and sudden, but it doesn't have anything to do with the pupil being mid-dilated. CSR is not painful at all. Cataracts is not sudden, nor is it painful. So this answer is quite clear, and most of you have got this right. Absolutely wonderful. What else? The next question is, there is a loss of vision, but there is a history of intake of ATT, anti-tubercular drug, some therapies. So which is the most probable drug? Now here, remember, is a combination of pharmacology as well as ophthalmology. You have isoniazid, ethambutol, rifampicin, and thiazonamide, and I think everybody should have got this right. It is indeed ethambutol. Okay, remember that both ethambutol and isoniazid, INH, that is, they can both cause loss of vision. Okay, but the most common is ethambutol. So if you have a choice, ethambutol, go for it. Go for ethambutol, and if you don't have ethambutol, you can go for INH. Also, that also causes loss of vision. And this is, I've often talked about this when we talk about toxic optic neuropathy, is it not? Certain drugs which cause loss of vision due to damage to the optic nerve. The three most common being, first is tobacco, second is alcohol, and third is ethambutol. So this is ethambutol. This is the answer. This is so far so good. We are not in any dilemma. Vitamin deficiency. Now, what I understand is that you had a picture of Bitot spots. It was one of the simplest questions ever asked. It's these foamy white secretions, you know. So, you're on the conjunctiva, you will have this yellowish, whitish, foamy white dots like this. Okay, they are called as Bitot spots, and they are a sign of vitamin deficiency. Absolutely simple question. Many of you have told me that it was so simple that you had to check it again in case there was a trick question there. Well, sometimes the questions are so simple also, you know, but not always. Very well. Then you have another very simple straightforward. As I said, they are straightforward. I mean that means it doesn't have too much jiggery pokery and trickery there. Okay. So, history of blunt trauma, and got this lovely star shaped stellate cataract, and what this kind, we all know this is the famous rosette cataract, is it not? It's a rosette cataract. So, with blunt trauma called rosette because it looks like a flower, like the petals of a rose. So, this is called a rosette cataract. Okay. So, that is why the history of blunt trauma, and this is the rosette cataract. Again, most of you have got this right. Those of you who attend the classes, those who have seen online, offline, whatever. Very well. So, we are doing fine now, and if you have a little bit of patience, I will just tell you maybe another 5 minutes, we will finish this. Then sudden loss of vision like a curtain falling down, dear me. Very simple. Typically, patient says like a curtain falling down and you have sudden loss of vision. This of course is retinal detachment, is it not? Is retinal detachment. This is sudden loss of vision like curtain falling down is like a retinal detachment. Okay. So, that is absolutely correct. So, this is, you all know this, you have floaters, you have flashes and a sudden loss of vision, which is looks just like a curtain falling down and blurring out all vision. Which of the local anesthetics used for cataract surgery? We have here proparacaine. Remember, if you have a choice, there's some doubt here. So, lignocaine we don't use anymore because not so long acting. Lignocaine 4% in any case, the topical anesthesia is 4%, 2% is injectable anesthesia. Nowadays, if we use for injectable anesthesia, we can use lignocaine 2%. If we want to do just surface, that means which is what we do topical anesthetic nowadays, then we use proparacaine. So, answer is proparacaine here. Which of the following is the corrected refractive error? And here you see, look at that, you have some pictures, you have myopia, hypermetropia, presbyopia, astigmatism. So, you will have a picture, and these pictures are actually make no sense here because they look weird, but we can try this. Okay. So, let us look at the pictures, myopia, hypermetropia, astigmatism, and you see the first picture here is rays of light falling in front. Okay. So, that is correct, this is myopia. And you know that astigmatism will have, let me, since these questions, this diagram is a little, and this is corrected myopia. So, you see this myopia in retina in front of the patient, and you wear a concave lens, the rays focus right on the retina, this would be myopia. Hypermetropia, rays of light would focus behind the retina. So, this is not hypermetropia, this is not correct, and astigmatism will have. So, in case I am not getting the question how it was asked or framed, but it should be like this. So, remember in myopia, the definition of myopia is that the rays of light focus in front of the retina, and how do we correct it? We correct it by placing a concave lens like this, which will focus the rays on the retina. So, this is myopia and its correction, right. About hypermetropia, it will be the rays of light will be focusing behind the retina, will be focusing behind the retina like this, and here we need a convex lens like this, and this will force the rays focus on the retina. So, the correction of hypermetropia would be with the convex lens. With astigmatism, the diagram would have two different foci. Okay. The two different foci will be something like this, one ray in front, maybe one ray and also in front, this compound myopia, and this will be corrected by a cylindrical lens or a toric lens, one axis correcting this one, the other correcting this one. So, toric lens for astigmatism, and presbyopia would be the near rays. Remember how do you near rays? Because they would be divergent, they will become parallel later and focus later. So, they will be focused again by a convex lens. So, this will be out. So, kindly remember both hypermetropia as well as presbyopia will be corrected by convex lenses. The toric lens, cylindrical lenses correct astigmatism, and myopia is corrected by the concave lens. So, this is actually the answer to this. I am not sure exactly how it was framed in it because we got conflicting opinions upon this. Okay, very well. Then according to WHO, very standard question, what is the definition of blindness? Remember, it is less than what? Less than 3/60 with correction, which means correction means with glasses and in the better eye. So, kindly remember, we call this as BCVA. The BCVA stands for best corrected visual acuity, best corrected visual acuity. So, it is less than 3/60 in the better eye, with wearing glasses. Okay, remember, so it is not without glasses. So, if you wear glasses or you wear contact lenses, so wear that. And wearing glasses or contact lenses, if the vision is less than 3/60 in the good eye, then it is blindness. It's not. So, supposing you have vision, let's say 1/60 in one eye and 2 by 60 in the other eye. Okay, or let's say you have no, let me make it more easy for you. So, suppose you have a patient who is having 6 by 6 in one eye. Okay, you have 6 by 6 in one eye and the other eye is 1 by 60. Okay, now this is not blindness. Why? Because this is the better eye. It's always the better eye that you take. So, this is 6 by 6 in the better eye, so it is not blindness. However, if you have 1 by 60 in one eye and 2 by 60 in the other eye, this is the better eye and you see that this is less than 3 by 60. So, this is so this would be blindness, but not this. So, kindly remember the definition of blindness states that the vision in the better eye should be less than 3 by 60 wearing glasses or contact lens. So, whatever that he has. So, best corrected visual acuity. Okay. So, this is the definition of blindness. Then cherry red spots is syndrome. Cherry red spot we know is in CRA, all of us, but there are other cherry red spots in other diseases also, and here this is the most common is Tay-Sachs disease. Okay? Tay-Sachs disease, which occurs to Ashkenazi Jews, genetic disorder, and the patients often die out quickly. So, they all develop cherry red spot. Tay-Sachs disease is another. There are actually many other diseases which we have cherry red spots. Okay? So, Tay-Sachs should be number 2 on your list after CRA. Then the next question is sudden loss of vision with no fundal glow and there is no history of trauma. Okay? So, see, you have sudden loss of vision, okay, and there is no history of trauma, but there is no fundal glow. Now, what is this fundal glow? Remember, the normal eye you should have, when you have a normal red glow, you take a direct ophthalmoscope and you see you have a normal red glow. Okay? It is called normal red glow. So, there is no fundal glow. When there is no fundal glow, it simply means that it is full of blood and the answer is vitreous hemorrhage. Okay? You all remember we have taught this. So, normally you should have a red glow of the eye, red glow. This is a normal eye. If there is no glow, okay, as in this case, this is called vitreous hemorrhage. This is vitreous hemorrhage, will be no glow. Okay, and if you have a grayish colored glow, you should all remember that is retinal detachment. So, we have these 3 different questions, 3 different glows: red glow, normal, no glow, vitreous hemorrhage, gray glow, retinal detachment. Okay, so this is vitreous hemorrhage. Very well. And the next question is, and then I think that's all that we have got here, and I'm almost finished. One more question which is not in my presentation, but I understood this from talking to many of you, is that you were asked to demonstrate that the patient has a lateral rectus palsy. You know the lateral rectus supply the 6th nerve. Okay, so how do you know the lateral rectus is paralyzed? Okay, so how will you test the lateral? In other words, okay, so suppose what will you see? In lateral rectus, you know, cause abduction. So you ask the patient to look. If it's the right eye that is suspecting, ask the patient to look like this. So as you ask the patient to look to the right, abduction, you will see the eyeball is not moving. You can see my eye moves out to look at this. Not my eye from center, it moves out like this. But if his 6th nerve is paralyzed, then the right eye lateral rectus is paralyzed. It will not move out. So ask me to look here. On the other hand, if you ask the patient to look in the left side, remember this is the medial rectus. This is going. The eye move from center to inwards is the function of the medial rectus. So we are not testing the medial rectus by asking the patient to look to the left. So you want to test the lateral rectus, you ask the patient to look out in the right eye. So similarly, lateral rectus in the left eye, ask the patient to look out like that. Okay. Similarly, you see there are many ways to test the normal muscles. So for instance, you know that when you look up, there are 2 muscles working. Okay. When I look up like this, there are 2 muscles. What are that? One is the superior rectus, second is the inferior oblique. Okay. Superior rectus, inferior oblique. So what happens? So supposing when I look up like this in the center, okay, like this, so both the muscles are acting, superior rectus and inferior oblique. But suppose I ask people to look out like this, upwards and outwards, then only the superior rectus is being tested. And suppose I ask the patient in adduction and elevation, then only the inferior oblique is acting. But in the center, both are acting. Okay, so there are certain times. So when you want to test superior rectus, ask them to look upwards and outwards. The inferior rectus, downwards and outwards like this. Okay, inferior oblique, upwards and inwards like this, and superior oblique will be downwards and inwards like this. Okay, that way. So this is a question. If I understand it's not in my PPT, but I'll have it ready in a couple of days. Is that when you ask the patient to look out or look to the right in the right eye, then you're testing his lateral rectus, and that is paralyzed. Okay, ladies and gentlemen, and that I think is about all the questions we have here. Thank you very much, and I hope you all have done well. And if you have any questions, I'm waiting for these questions. Otherwise, I'll be back in a couple of days with a full PPT and with color pictures. Thank you very much, and may you all pass. Those who are watching at least, may you all pass. You should have done very well. Thank you very much.